USMLE style question. Iron deficiency after Roux gastric bypass. A 45-year-old woman with a history of obesity undergoes Roux gastric bypass surgery to help with weight loss. 3 months after the procedure, she presents to the clinic with complaints of fatigue, weakness, and pale skin. She also reports dizziness when standing. Her medical history includes hypertension, but she has no history of gastrointestinal bleeding. She is not on any medications. Laboratory results are as follows. Hemoglobin, 9.8 gram, 12 to 16 grams per dose. Mean corpuscular volume MCV, 75, 80 to 100 Fevlode. Serum ferritin, 6 nanogram milliliter, 15 to 200 nanogram milliliters. Serum iron, 30 microgram milliliter, 50 to 120 grams per dose. Total iron binding capacity, increased. Transferrin saturation, low. Reticulocyte count, low. Which of the following is the most likely cause of this patient's anemia? A. Vitamin B12 deficiency due to malabsorption. B. Anemia of chronic disease due to hypertension. C. Iron deficiency due to impaired iron absorption. D. Chronic gastrointestinal blood loss. E. Folate deficiency due to inadequate dietary intake. Answer and explanation. Correct answer. C. Iron deficiency due to impaired iron absorption. This patient has iron deficiency anemia after undergoing Roux gastric bypass surgery, RYGB, which significantly impairs the absorption of iron. The surgery involves rerouting the small intestine, bypassing the duodenum and proximal jejunum, which are the primary sites for iron absorption. Mechanisms of iron deficiency after Roux gastric bypass. 1. Decreased gastric acid production. This reduces the solubility and absorption of non-heme iron. 2. Bypassing the duodenum. The duodenum is where iron is absorbed most efficiently. 3. Reduced iron intake. Many patients with obesity also have poor dietary iron intake, and after surgery, appetite and eating patterns can further limit iron consumption. Lab findings. Consistent with iron deficiency, low hemoglobin and low MCV, microcytic anemia. Low ferritin, low serum iron, increased TIBC, and low transferrin saturation confirm iron deficiency as the cause of anemia. Low reticulocyte count indicates impaired erythropoiesis due to insufficient iron stores. Why not the other choices? A. Vitamin B12 deficiency. Although vitamin B12 absorption is impaired after gastric bypass due to bypassing the ileum, it typically causes macrocytic anemia with elevated homocysteine and methylmalonic acid, which is not present in this case. B. Anemia of chronic disease. Common in inflammatory conditions, but this patient's anemia is microcytic, which is more consistent with iron deficiency. In ACD, ferritin is usually high normal or elevated, not low as in this case. D. Chronic gastrointestinal blood loss. There is no history of gastrointestinal bleeding or ulceration in this patient, and her anemia is more likely due to iron malabsorption rather than blood loss. Folate deficiency typically presents with macrocytic anemia and is not consistent with the lab findings or the patient's surgical history. Key learning points. Roux gastric bypass can lead to iron deficiency anemia due to impaired iron absorption. Iron is absorbed in the duodenum and proximal jejunum, which are bypassed in RYGB. Post-surgery, patients may require iron supplementation and dietary modifications to prevent or manage iron deficiency. Microcytic anemia, low ferritin, and increased TIBC are characteristic findings of iron deficiency anemia. Would you like more questions on bariatric surgery or nutrition-related complications?